The way that we've done this, and to me it's really fun, is we're going to talk about the survey, and I'm the straight man. And Stephen Linder is the color commentary. So the way we work this is there are some things, not all, so don't worry, it's not going to be twice as long. There are some things that we will talk about together and some things we won't. And we will attempt to get through this in about the first third of the time. And then we have an amazing panel that you've all seen there, seen on the way in, headed up by Mary Agnes Carey, who we will introduce when she's ready, but all the way from DC. We also, where's Roz? There's Roz. So Roz Pearson is the lucky person who, when she worked for Nielsen, took some of the, the good people from Nielsen with her when Nielsen decided not to do healthcare anymore, started her own business called Luminos, and they are wonderful. For anybody doing surveys, call Roz or get a hold of us and we'll get a hold of Roz. So really, I'm delighted that you're here, Roz, and if we got the slides mixed up, sorry, but we'll see if we can't do it right. Okay, so the person, where's Ryan? There's Ryan. So Ryan is the guy, Ryan Hollywell, it runs communications for the whole medical center for TMC and is a wizard. And so we thank Ryan for really getting this thing up and running and together, telling us all kinds of good things that are important. I see Tatum back there. There are all kinds of people. Wendy, thank you all. I'm going to blow it again and not be able to sort of thank everybody, but let's get started. The fourth year, and I thought this was going to be terrific. I had this graphic with a big stone IV, 4, and it was going to be like Super Bowl 23, except it was Survey 4, and they took it off. So it's year 4. Big survey, 5,000 participants. The usual ABC News is around 1,000. And so this is a very large survey. The reason to say that is we're going to talk about sort of statistical differences. The differences you may think between 37% and 40% are not statistically different. Guess what? At 5,000 people, they are. The surveys actually started in May. I think importantly, and we've got a few things at the end that are sort of fun slides, you want to be thinking about what has happened in DC and the rest of the world really since July, recognizing that not all of the comings and goings since July are here. Luminos we've talked about, and there we go. We split this up into, said, okay, how are we going to think about fixing healthcare? And one thing we thought right out at the onset is, okay, what's important to people? What do they really want fixed? Not how are they going to fix it, what do they want fixed? Then we split out, these are all, remember, these are regular, randomly selected American people, health insurance and healthcare delivery. That's certainly a system way of fixing things, but so are healthy lifestyles. Think about what smoking costs. Think about what alcohol costs. And so in order to try to fix and reduce the cost of healthcare, some of it is system, some of it is hamburgers, not cheeseburgers, and some of it we just thought we would maybe get a little look into the 2020, just a couple of questions about 2020. So first question, we said to people, what's important to you? What is it? And interesting, certainly to us, reducing healthcare costs, #1 across the board. Now, a couple of us were talking to a couple of newspaper folks a couple of days ago, and they said, what's the difference between cost and the affordability, well, to me, big deal. Healthcare cost is everybody else. Affordability is me. And so I think it's both that are important to people. It is interesting if you just take a minute to look down, that's more important than life expectancy to people, more important than paperwork, more important than easier to understand healthcare bills. None of us have ever had a problem trying to understand a healthcare bill, but maybe some people do. So we then said, let's look at Democrats, Republicans, and Independents. And the first are the same, obviously, the ones that are sort of blank, reducing costs. Democrats, Republicans, and Independents, different. Universal coverage for the Democrats, affordability for the Republicans and the Independents. But when you then get down to the next one, the Democrats flipped. And so you don't get to universal coverage with the Republicans until fourth place. The Democrats and Independents' universal coverage is important to people. Stephen, talk to us.
You hear a lot about independents, especially in the swing states, and the role they play in close elections, where they really make a difference after all the partisan votes are counted. You still have this group who can ally with one candidate or another of one party or another. So what does it mean to be an independent? Well, usually independents are disaffected Democrats or disaffected Republicans, and so they refuse to say they're affiliated with the party even if they vote with the party. So some of it is they reside right in the middle between the two parties and switch between the two parties. Other factors are the primary systems. We've got a semi-open primary in Texas where if you vote in a party primary, for 2 years you're aligned with that party, but then for the next issuance of your voting card, you're not aligned at all. So you can vote as an independent in the general election even if you voted as a Republican or a Democrat in the primary. That's true in 21 states. Another 12 have closed primaries. You've got to declare if you want to be part of the primary process. You can still vote as an independent in the general election, but your voting card will slot you as a Democrat or a Republican because of your participation in the primary. So we're going to watch how the independents align themselves relative to the Democrats and the Republicans on subsequent slides. And for a lot of the slides, you'll find that they occupy a middle position. And you can tell whose issue it is by the party that leads. So if it's Democrats, Independents, Republicans, then it's a Democratic issue, and you've got Independents as the swing between the Democrats and the Republicans. We're going to see that that alignment doesn't hold when it comes to looking at some of the lifestyle factors, but we'll get to that.
One other sort of housekeeping thing, pretty much, if you see the United States there up on the top right, these are national data, and if you see both Texas and the United States, we've got both. But very interesting to me, with few exceptions, Texas was not statistically different from the US, which was very interesting to us for later discussion, perhaps. Okay, we asked a number of questions that are like this, that says, well, okay, if you feel that way about something, is it important that you vote for somebody that feels the same way? And so these questions fall into, and most of them are colored this way, but this one is the one that sort of knocked our socks off. About 2/3 are likely to only vote for candidates who will make fixing healthcare a priority. Now that's sort of interesting. It's become a big deal. Now, if you look over to the right, 68% of Democrats, still 60% of Republicans, and 53% of Independents. I might put Stephen on the spot and say, what is it that it seems, and we'll see this moving through it, that the Democrats are higher, that the Democrats, when you say, is it important to you that you line up with the person that you're going to vote for? The Democrats are pretty much consistently higher than the Republicans. So they seem to care more about the person that their own, I want to agree with that person. Is there a thought about that?
Well, there are very few independent party candidates. The candidates are allied with one party or another. And if you're an independent, you have to choose to go with the candidate or go with an issue in deciding how to vote, because the party label you've decided won't influence your vote. So in effect, the Democrats will align themselves with the Democratic Party nominees, likewise the Republicans for the most part. And independents, it depends on who the candidate is, and it depends on the issues they select.
All righty. So now this is back to US versus Texas data. I have to cut down on other expenses to pay for health care. US 49%, Texas 56%. Statistically different. Texas are finding it more difficult to pay for health care than 2 years ago. Similarly, out of pocket. And I don't seem to think out of pocket is a real tough thing to understand, but apparently there's confusion about it. It's what is you paying for the year? That's it. It's what, and it's generally, it's not the insurance premium unless you're paying it. It's what actually you're paying, not what your employer. But here we go, national 59%, Texas 65%. So in both of these, Texans are finding it more difficult to pay for health care than 2 years ago. Now, we then said, if you get a bill, what do you do when you get it? 38% say they pay it right away. Now, the one down there that says don't pay until the collection agency calls you was me. Okay, I put that in. As you can tell, I've been a patient plenty in my life. And I'm not being completely facetious. The bills keep coming, and then they say this isn't a bill, and then they say it is a bill, just kidding. And it goes on for months. And so I finally said, all right, after one operation, certainly not in this state, in Virginia, I said, I'm not paying until the little envelope shows up from Long Island City, and says, congratulations, we're going to come after you for $8.36. My own hospital, $8.36. So, at least it got down pretty low. Obviously, the United States does not agree with me. Okay, they don't want to wait for the actual letter to arrive. But all the way down there at the bottom, don't pay at all. So, Stephen, thoughts?
So if you look at the blue category, pay what I can when I can, and put that together with the orange categories of 7% and 3%, we've got a third of the respondents saying that they don't pay according to the rules, in effect, or can't pay according to the rules. And this supports that trend towards increasing bankruptcy based on medical expenses that we see. It's incrementing upward over time.
Now, there are a couple of shockers in these data. This one, to me, may classify as a shocker. So we said to people, do you want to discuss cost? Is it important to you to discuss cost? Well, heck, only half said it was, right? Those are the blue numbers off to the right. This is patients want to discuss the cost of procedures, the cost of drugs. How about whether you can afford it? Who are we talking about? The doc. When you go to the doc's office, I'm sort of surprised only half the people want to know. Now, again, this may be people who have insurance who have met their deductible and don't care. There's some things that we want to drill in on next year, but of the half that said they wanted to discuss it, only half of them did the doc discuss it with them. So that's the numbers on the left. About half of the half are saying, yes, the doctor did discuss with me the cost or whether I can afford it. In that same vein, Texans and the US similarly, is there difficulty in choosing a doctor that you want to see and a hospital that you want to see? And lo and behold, both the doctor and the hospital, compared to 2 years ago, it is tougher for people to go see the doctor and the hospital they want to see.
So there's two questions that lurk behind this slide. One is, how important is choice to people at this point in the development of our healthcare changes? And the other is, when is there too much information? We were always operating on the assumption that there was too little information and more information needed to be put in the system so people could choose doctors and choose hospitals on some rational basis and be better informed consumers, and that would make a difference. And it may be that there's substantial amounts of misinformation and information that's hard to corroborate now available, to the point where people have too much information, and the choice is much more difficult than it was even when they had much less information.
Okay, on to health insurance and delivery. Now, this one is worth pausing just for a minute to think about. So we asked the people in states with Medicaid expansion. And I was off talking to a couple of reporters a couple of days ago, and they said, nobody knows what Medicaid is. And we said, well, we defined it. We told them what it was. Did the same thing with Medicare. I went back and looked real quick and hoped that we did. We actually did. And so in states that currently have expanded Medicaid, 76% of people want to keep it. Now, think back a few months ago to the American Health Care Act, the AHCA, and the people who already have Medicaid were very, very close to losing it. But here's the 76%. Now, here is the states that said, we're not expanded. Okay, Texas being a non-expansion state, 64% want Medicaid expansion, and we put a little Texas down there of 60% of Texans. And of that, the big 64% in the non-expansion states, still 51% of Republicans. So there does seem to be, certainly it isn't unanimity when you're talking about 81% of Democrats and 51% of Republicans and 59% of independents. Stephen, thoughts?
Let me call your attention to the party affiliation ranking here between the Democrats, Republicans, and independents. Basically, you've got the Democrats, the independents in the middle, and the Republicans at the bottom. So think about a left-right alignment with Democrats, independents in the middle, Republicans on the right. And whose issue is it? Well, it tends to be the Democrats' issue. And the independents, to the extent that they're disaffected Democrats, will join the Democrats and make it their issue. But you'll see this alignment, left, middle, right. You saw it on the last slide, on this slide, and you'll see it on subsequent slides until we get to lifestyle.
There's the last one.
Okay.
Now, think of the things I can do. Just say it. Okay, here we go. Now, again, this is the color scheme for what's important about the candidate you vote for. So whatever they said about Medicaid expansion or not expansion, here those in expansion states say it's important almost 3/4, right? In the expansion states. I think that, again, this may be my deficit, probably is, but I don't tend to think a lot about the expansion states. I think a lot about the non-expansion states, and good grief, here the expansion states are making it real clear that they want to keep it. These are the non-expansion states, 65%.
So we're still seeing the alignment, again, left, middle, right, across those three categories of voters.
Now, we then asked about some of the changes that have been proposed over the last 18 months. And again, to those of us thinking about this, it's very interesting. Remember, this is now. And so here we're saying 18%, as in 82% not, would limit the total amount of federal government pays per person. Now, you may have heard the term block grant. That's what this is. We didn't go say this is a block grant. We said limit the total amount would pay per person. Allowing states to limit the number of months an adult can be on Medicaid, 14%, and then excluding any poor adults from receiving Medicaid unless they are disabled, 10%. Now, when you look at that, that says 90% of 5,000 people are saying that it's important to them that people who are poor have access to Medicaid. Now, that's a big number, and I think, we'll go back to Roz and say, did they really mean that? Because it's an awfully high number, but that's the way the number is. I think it would have been fascinating to have had these same data right around the time that the AHCA was being negotiated or talked about, but we don't have that. Now, Medicare, okay, Medicaid, state program, state federal program, Medicare. 59% of the US, Medicare for all adults. Surprising to many of us. And again, importance that the candidate feels the same way, pretty darn high again. And again, I went back and looked, and did we describe in the wording just what this meant? And we did. And so this does seem to be something that people are talking about. There are other things that at some point later in life we should talk about. I have this idea called a single safety net, that really the current people that are talking about Medicare for everybody are talking about getting rid of insurance companies. And I think that's probably not a good idea, personal opinion, not a good idea to get rid of insurance companies. You don't have to. You have a single safety net like public school for people who want public insurance, who pay for it, and then you can have an insurance. That's only 95% of other countries. Now, this sort of rounds out the ideas of what people might want to do structurally. So we talked about Medicaid, talked about Medicare, and here we are saying, what would you think, America, about having a catastrophic health insurance plan, which would cover pregnancy, which would cover chronic disease, which would cover accidents, which would not cover colds, sore throats, those sorts of things. This is of interest to a number of us. 56% came out in favor of it. There's a lot of digging that we have to do to really understand this. But if you imagine that, right now the Affordable Care Act has really only up to age 30 that you can get a catastrophic plan, and still the deductible is $6,500. Okay, well, that's moderately prohibitive. What we're talking about, and what I think we're going to try to investigate some, is what if the deductible's low? What if it's $1,500? Would the well people of the country buy it and therefore support it? Don't know. Food for thought. Stephen.
So the party affiliation here is different. It looks as though this is, at least among the voters, a Republican issue. Republicans supported higher, independents taking the middle position again, and Democrats on the left with a lower level of support than is the case for the Republicans. But there's a split here that is important and will carry over to the next slide, and that's the urban-rural split. And notice the alignment here. The difference between urban and rural is 14 percentage points. You're going to see that same 14 appear next time, only it's going to be different.
Ta-da. So we were interested in where the heck does America get their primary care? And it turns out only 55% of America gets their primary care in a primary care physician's office. The rest of them get it in all kinds of other places, certainly freestanding emergency rooms, specialist's office. They're saying they get their primary care in the specialist's office. But really only about half say that they get their primary care in the PCP's office. Stephen.
This is reverse, of course, if you look at the urban-rural-suburban alignment of what we saw on the earlier slide when we were looking at catastrophic health care. It's clear that the rural areas see their physician in a primary care office, and it may be that that's a relatively exclusive choice, that there aren't very many options. The responses to this suggest that there's a fundamental difference in the structure of available health care between urban and rural areas, which makes perfect sense.
And you know, right, so if we sort of review this past few slides, it's about half of a lot of people are saying they'd like to see certain changes occur. Half would not. So we want to be careful of saying, oh, you know, everybody wants to do this. No, only about half people want to do it. Now, my favorite. I don't think we may be having cheeseburgers in about a half hour, so I better move and get going. Okay, so menu labeling, radial green. If you go and look at the menu from Third Coast here, you'll see a few things that are red, some that are yellow, some that are green, related to calories. And so what we found, and you're going to see we asked, this is about food. I want to give the MBA students at Rice a real shout out, because this whole thing came up in about 1991 when I was at Rice teaching a unit to the MBAs on healthcare. And I said, okay, at the end of this unit, you're going to create a healthcare system for the United States, 1991, and you're going to figure out how to pay for it. And there was grumbling, as you can imagine, but they did it. And the last group that presented created a sin tax, and they said this is not S-Y-N, S-I-N, increased sin taxes to pay for the uninsured. And all of a sudden I said, wow, isn't that neat? Let's look at this carefully. So they said a fast food tax. And I said, can't do a fast food tax because McDonald's will decide they're making slow food. So, you know, can't do that. But you could certainly have a tax on things that have a certain number of calories in it, call it a fat tax or something. But what this shows is that really 70 or so percent, pretty much distributed pretty evenly across groups, would like to see menu labeling. About half agree that foods that lead to obesity should cost more. Some have called that a fat tax, and you're aware some of that is drinks, some of that is food in different parts. Not only of the country, this actually started in Europe, and it turns out that the French decided that they were only going to tax high caloric things that were Italian. So think about that one. Okay, now, this one is, to me, really interesting. Half of Americans, 46%, support lowering the legal blood alcohol limit while driving to 0. Huh? 0. Now, note what that means. Any of us that have a glass of wine with what we're about to have can't drive. And that's, you know, you can imagine lots and lots of people just hate that. But it's really interesting to us that 46%, and then Texas is higher. Stephen.
It's also the case, this is the first instance we see the party alignment flip. And you have Republicans more in favor as though it's a Republican issue, but then Democrats follow on just barely significant in difference, and then independents trail. And so it appears to be the case that there is, different from the earlier signs we saw of certain issues being largely Democratic when it came to access to care, a displacement of the Democratic position in favor of much more regulation when it comes to certain lifestyle factors, and support among Republicans in the electorate for that kind of control.
Again, surprising. So here's T21, right, known as limiting sales of people only to those who are 21 and older, 82%. The reason for all, and I apologize if you happen to be colorblind, because there'll be a lot of colors here, but the point being, there's no difference, right? Everybody, you know, high school, no high school, insurance status, everybody thinks, and this is certainly, this is true in national, as you see, is 82%, Texas 83%. Now, this one, really? Okay. Half of Americans support banning all tobacco sales. Stephen.
So here we have an instance where, again, Republicans are leading this issue, Republicans in the electorate, and Democrats coming next, and it appears not to be a partisan issue as we understand the separation between parties and people in the electorate affiliated with those parties. They appear to be relatively close, and we don't really know why. We do know that the level of smoking is lower in Texas than it is in the national average. And in Harris County, we're among the lower counties in the country in terms of smoking at just 17% smoking. So there's natural opposition from non-smokers to having tobacco products widely available. And so the regulation appears to be bipartisan in this instance.
Okay, this is sort of a freebie. We wanted to really ask one question, and it really related to the 6 months before the election. The president said, and we all know that clip, of standing in the middle of Fifth Avenue, and he could do what he wanted and nothing would happen. That got translated into his base. And so we were sort of interested in, because everybody's talking about how solid that base is, and we were sort of interested whether healthcare made any difference to that base. So my hypothesis was no. Didn't matter at all, nothing matters. Well, so here's, we start out, go to the left, that 37% of the US, 38% in Texas, say that they, as of today, are planning to vote for the president. Go to the right, and they stated where they fell, and Republicans, very, very similar US and Texas. Independents, higher in the US than Texas in this one. Stephen's going to talk about that in a minute. And 11% again of Democrats. So this is still only, are you going to vote for the president?
So it appears to be that there are fewer independents who are Trump loyalists in Texas. That doesn't undermine the independents' role in other states, especially swing states. But in Texas, we're not a swing state. And in fact, over time, it's probably 55% Republican, 45% Democrat in the aggregate. And independents play a smaller role in determining any particular election than they do nationally in the states that have much closer contested elections.
I think we all, when you do something like this, hats off to Roz, because you sort of say, gee, I hope, because we have national data that can be compared to this, and this falls pretty well within what you'd expect nationally. Okay, so then we said the following. All right, the 37%, 38%, you're going to vote for the president in 2020. Would it matter to you if the president supported actions, in our case, increasing the number of uninsured? Would that matter? Do you care? 60% of Democrats say they would, 37% of independents said they would, and 35% of Republicans. This is national data. And so when you do that multiplication, you start out at 37% and you do that multiplication, and lo and behold, there's a 39% reduction in that number to 22.9%. It's early, it's 2 years away. We just sort of thought it was interesting that maybe the base isn't exactly, maybe the base does care about healthcare and care about the uninsured. Don't know, but it's interesting to see. So I think with that, we're a little bit late. Really, you guys have been great. You laughed at the right times. That's all that matters to me. That is our website. Ryan maintains one of the great websites ever. These slides will be on that website at some point, maybe soon. And I think what I would do is take no break at all and ask the panel to come up. And Mary Agnes Carey, where's Mary? There she is. So this is a big deal for us to have a star down here. Mac, known to her friends, come on up, guys. Mary Agnes Carey, Mac, is the partnerships editor and senior correspondent at Kaiser Health News, sort of our Bible, the yearly Bible, the daily Bible.
Hi, good to see you.
She figures out where Kaiser News placements belong. Fortunately, we get it. And she used to be the associate editor of CQ Health Beat, Capitol Hill bureau chief for Congressional Quarterly. That's an immense deal. P.S. Knows everybody in D.C. Got her master's in journalism from one of the great journalism schools anywhere, Columbia. And she's just a neat person. So I am delighted that she thought about, we go back, I guess, 60 or 70 years. Maybe not quite that much. But I am really thankful, Mac, for you to come. Please, at Mary Agnes Carey, one word, MaryAgnesCarey. I practiced that last night. With an at in front of it, her Twitter feed, do it. Thank you all, and we'll turn it over to Mac.
Do you want to sit here?
Yeah, thanks.
Tim, did you want to introduce panelists?
Oh, yeah, sorry.
Yes.
Cool. So you have the panelists on your sheet, and let me from left to right, and Max said, well, do you want to read paragraphs about all of them? And I said, look, these are the people that teach all our courses, and we all know real well, but some of you may not. So Vivian Ho on the far left, the director of Center for Health and Biosciences at Rice Baker Institute for Public Policy. Peggy is next. No, who's, yeah, Peggy's next. Perry, oh, did you line up like this? You guys are so smart. Thank you. Peggy Landrum, clinical professor of nursing at TWU. Jessica Mantel, a lawyer, co-director of the Health Law and Policy Institute at U of H. Aisha Moultry, a pharmacist, a PharmD, associate dean of academic affairs at Texas Southern. And Steve Spann, who almost should get his own round of applause. This is the guy that's starting the University of Houston Medical School with his bare hands. So, where'd Aisha go?
Aisha?
Yeah, there she is. Oh, okay, there she is. God, I missed it. Okay, great. Where'd Aisha go? Okay, so Aisha's there. Okay, great. Folks, thank you. Take it away, Mac.
Okay, thank you. Thanks for that nice introduction. My teenage daughter could not probably believe that somebody would say all those wonderful things about me, so that was very nice. For those of you who have daughters, know what I'm talking about. So tonight, what I'd like to do is dig in on several areas that we just heard about, the top lines and where the parties are breaking out. I really want to look at things that we write a lot about at Kaiser Health News. I know you all care about affordability, the Medicaid expansion, this idea of Medicare for all. It means a lot of different things to a lot of people. Some of the healthy lifestyle information was very interesting, and how healthcare is going to fare not only in the midterms, because we're hearing a lot about it, Democrats are running on it versus running away from it, and also looking at the 2020 elections. It is 2 years down the road, but you can kind of see how healthcare is shaping, how that message is shaping. So I'm going to start here with the panel, but your participation is incredibly important to us. So I'm very watchful of the clock. We're going to get started. We may not get through my list of questions, but I do want to get you involved. So as we talk, think about what you want to ask about and what you've seen and what you'll hear from this panel. So with that, I want to dig into the idea of healthcare costs and affordability. As we know, as Tim went over, reducing health costs was the top healthcare priority across all the parties. That was really fascinating. Closely following that, healthcare costs was increasing the affordability of health insurance, the premiums, the deductibles, and then universal healthcare was also incredibly high there. So let's dig in a little bit about the price of healthcare and how much people are expected to pay for it. One thing that really caught my eye, and Tim also touched on this, 6 in 10 respondents say they're paying more out of pocket for their health care this year than 2 years ago, and in Texas, it was higher than the national. So Vivian's right here. I want to start with you. I know you're an economist. Can you talk a little bit, we have this discussion all the time in my newsroom, why is health care so expensive, and how can we make it more affordable for the average person?
Well, you know, another very important person at Kaiser Health News is Elizabeth Rosenthal, who's written a terrific
She's our
book,
editor-in-chief.
called An American Sickness. And if you read this book, you will see example after example of all the players, all the providers in the healthcare market charging whatever price they want, whether it's, and it's not related to the cost, it's related to how much money they can possibly get out of the insurer and the patient. And so there's a combination of prices just not at all being aligned with what a service is really worth. We're paying for quantity rather than quality. And attached to that, another book that I just finished recently called Overcharged, which is written by, I think, Charles Silver and another author, has many more examples of things that are just outrageous and really get you upset. And what they tie into that is the reason why providers can do this is because we all have very, very generous health insurance. And so every time our health insurance ratchets up, for example, adding Medicare Part D actually allowed pharmaceutical companies to charge more for their drugs. And this has been shown with the introduction of Medicare in the 60s. That's when you saw the first initial ratchet up and increase in health expenditures. So it's a tough situation, and so that's why healthcare has become unaffordable. It's these prices go up. The insurers have to put those prices into their premiums for the following year. That therefore makes health insurance unaffordable to more and more Americans.
But are there also fees that are being charged perhaps that necessarily contribute to high costs? At Kaiser Health News, we have a Bill of the Month feature. We've been doing it with NPR. The last one we did was about a gentleman whose insurer had paid about $50,000 for a heart attack coverage. He'd gone to an out-of-network hospital, but he was in acute chest pain. They tried to balance bill $109,000. Another Bill of the Month was about an $18,000 trauma fee assessed to a family whose infant son had basically fallen out of bed at the hotel, bumped his head. He was perfectly fine. He had some formula in the hospital. He slept in his mother's arms, and they got a trauma fee of $18,000. So are some of these fees necessary? Maybe they are, maybe they aren't. I don't know if other panelists, Steve, you want to jump in?
Well, part of that is cost shifting, and when hospitals have to take care of a significant number of folks who don't have insurance and don't pay, they make that up by shifting costs to those who have insurance. So I think that's one of the significant problems.
Anyone else on the panel have any thoughts about what we're paying, what we're charged?
It just occurs to me that, along with that, Steve, that we pay, period. You know, it's like we may say, well, we're going to, we don't want to pay more. We don't want to have, like, Medicare for all was an issue.
Right.
But we're still paying, and that, I think that's your point, you know. So the hospitals, they'll end up charging more. Somehow we pay for it.
I do think another part of the story is not just the price for the service, but the type of service that we're all getting. We love, you know, whatever's new, right? We love medical technology, and it's just more expensive to go have the surgical treatment than, let's say, physical therapy. And so I think we're very enamored of that, and as long as you have insurance and a physician thinks this is going to be a little bit better, even though it's a lot more expensive, that's what you can do.
Aisha, can I ask you to jump in here on the prescription drug front? A lot of patients walk into their doctor's offices, right, and they've seen an ad on TV and they want this particular drug. How do you see that factoring in to costs? And also, we have seen some prices of generics or insulin, for example, have really jumped up a lot. How is that all factoring in from your perspective on the cost angle?
So, of course, the cost of prescription drugs is an issue, you know, for all, where patients do have to make those hard decisions. And so when a patient comes in to the physician and they say, you know, I saw this commercial, I was up, and oh, I do have insomnia, I need that drug, you know. And so they come in, and so that's part of the direct-to-consumer advertising, and so there's the pros and the cons associated with it, because we're in an era of all access. We have information available to us at any given time. We want to go into the physician and we want to be able to get these medications. And so that is part of the marketing that the drug companies are doing in order to get those medications. The problem is that the patients don't understand what that cost is really going to be to them, that out-of-pocket that they may not really get when you go outside of your formulary, because just as we have with our managed care organizations that you have to stay within network, we know within healthcare organizations there are these formularies that, you know, the patients have to be a part of, and if you are not following it, there are the costs associated with it. And so while the physician, even if it's not about the patient saying, the patient coming in and saying, I need this, or the physician saying, I really want you to be on this, when they get to the pharmacy and the pharmacist says, this is how much it's going to cost, and they pitch a fit with the pharmacist, you know, and all we can really say is, well, you know, I put the information in, this is the cost that came back to me, and this is what it is, explaining that to the patient. And so the patients truly don't understand the full process. That is something that we see, but then it goes back, that cost does go to the patient if they want to stick with that, or it will be the pharmacist's time, if you will, calling the physician to find out, hey, this patient was on this medication, but we do, you know, they can't really afford it. Can you prescribe something such as this that's a little bit cheaper, that's even more affordable for the patient to receive? So, you know, there are a lot of different factors, but direct-to-consumer advertising does have an impact, positive, negative, however you want to view it. But on the side of cost, there is impact there.
I want to hit on a couple of different things that were raised in the slides that are ways that providers and consumers are trying to tackle this cost issue. One is this idea of people talking about they're having a harder time maybe seeing the doctor or provider they want to see. This idea of narrow networks, where the choices offered in the health insurance plan are narrower because the insurer is trying to drive a discount with those providers, but then maybe people can't see who they want to see. That is one issue. And this whole idea of the catastrophic health plan. As Tim noted, it could be limited in scope, and the premium might be lower, but those out-of-pockets are huge. And I think we're seeing this in reporting at Kaiser Health News. People don't realize they've got a $6,000, $7,000, and $8,000, even higher for family coverage out of pocket. I just wondered if folks could jump in and sort of talk about how they've seen narrow networks. Does it really shape consumer behavior? Do they just get frustrated and then not maybe get the preventive care they should have? And have you seen patients deal with these high out-of-pockets on the catastrophics, or have you seen them work incredibly well for folks?
I'll jump in, particularly on the narrow networks. Really, for my own personal story, as being, I'm a healthcare practitioner, but I'm also a mom. And so I do have kids, and for instance, they had been going to a provider, and both of them have allergies, so they have an allergist they were seeing. But in order for us to get to that particular allergist, we had to have a referral before we could go see that allergist. And so we did that. And then the new year came, and I tried to go through and do the referral. And I was told, well, no, you can't go to that one. You have to stay within the system, so you have to use our allergist. And so in doing that, this is an allergist. We only have 2 locations that you could go see the allergist, and they're about 40 minutes away as opposed to 15 minutes away. And because you got 2 kids who need back-to-back appointments, it's gonna be about a month before they can come in. And then it's the, and we're still waiting on that appointment, but while I was trying to get the referral, even from within the system, I called and they said, well, they needed a prescription. They have EpiPen, so they need a prescription for their EpiPen, a refill for school. Well, we can't refill it because we don't see that you have an appointment in the system with the allergist yet. And okay, I called the allergist, but I gotta call them back because it hasn't posted in the system yet. And so I went through, I was very frustrated. Now, I'm a healthcare practitioner. But I was very frustrated with the system because of everything I had to do. And I'm like, there's no way I can go to the person I have been seeing. They have all, now we have to get all of this information faxed for the continuity of care, and I have to make sure, and of course I'm being persistent because I understand how important it is. But I think about the average person, and if they are going through this, how many would just say, forget it? Or that's okay, this took too long, why am I making so many phone calls? And so it takes a lot of time, and that definitely can have a negative impact on the type of health care that a patient is receiving, whereas, yes, this is their way of controlling costs, but you're also, now here I am delayed in getting my kids to be able to see an allergist. And, if they need to get special testing, we only do that at one location in the city, where I could have gone to that 15-minute.
I'm going to jump in just a second. We've got both Steve and Jessica want to jump in here. So
Yes, I would say studies kind of support empirically what you're saying. I mean, so obviously narrow networks may help drive down the price that insurance companies are paying for services, but there is this hidden cost that comes from discontinuity of care. So I think your story kind of helps illustrate there can be a delay in getting care, or care can be foregone, and that itself has big impacts on individuals' health, and studies point that out. And even when you do find that new provider that's now in network, they're not familiar with you, and it can take time to build that relationship. And the quality of care you get may suffer in the interim until they become more familiar with you.
sure, Steve.
I absolutely agree. False economies. Let me just remind us that 30% of our expenditures on healthcare are wasted. We do too many tests, we do too many treatments, many times not evidence-based, many times because of discontinuity of care and physicians repeat tests that have already been done. So I think there's some significant false economies there.
Talk about consumer behavior with this, Vivian. I mean, does it shape if you make consumers do more? We're getting some examples that maybe it doesn't have the desired effect. What have you seen?
I think it's, we're still early in the game. A lot of these narrow networks have popped up because of the Affordable Care Act. And the research is showing it's in the early stages. I sit on the board of Community Health Choice, which is Harris Health's, managed care insurance company doing Medicaid and marketplace plans. The CEO over there is Kenyon is there. And so going to his board meetings, I find out that there are network requirements for these plans. So in principle, there are laws requiring that the insurance plans have to have a reasonable network if you're selling, plans in these areas. So there are laws that exist. I think, clearly everything is not perfect, but I don't think we should turn our backs on this, because if you funnel more patients to a provider, they will be willing to negotiate a lower price. That's what these narrow networks are about. I think it's an IT challenge. It's very difficult to get this done, but I don't think we should give up on it, because look, this is taxpayer money that's going to this. And it's, do I want my money to go towards every person having access to every possible doctor in Houston? I'm sorry, no, I'm not willing to do that, and I don't think we should be doing that.
I want to move on to the Medicaid expansion. As we know, 33 states, the District of Columbia, have expanded Medicaid under the Affordable Care Act, expanding the eligibility for folks who make around $16,000 a year. That tends to be, this expansion group tends to be the single childless adults. Even though residents of Texas have said in several polls they want Medicaid to be expanded, it has not been expanded here. But Peggy, I wonder if you could talk a little bit about, if magic were to happen and Medicaid expansion came to Texas, how would that change healthcare here? And also broadly for the rest of the panel, if you know providers' experiences, patients in other states, what have been some of the impacts? In Medicaid, for example, we see states, Oregon is one I can think of, now starting to think about how do we pay our 10% share of that expansion. States that have had a higher uptake in the Medicaid expansion than they thought there would be. But there's also been economic growth and a variety of other factors. So maybe let's go first to the dream scenario, perhaps, for some, that Medicaid is expanded here.
Well, I wonder, my area is mental health, and so that's what I can speak to most authentically. And we have very poor coverage for mental health. Often policies are very restrictive in mental health services, and so what happens is that care's not accessible for folks. I do some work with Search, which is our homeless coordinator of services for folks who are homeless here. And Medicaid expansion here would make a huge difference for the population that really, they have health care, but they would have such a better kind of, better choices and broader choices about broader services if Medicare were to expand. I'm not familiar with other states. It seems to me that there's been a lot of frustration in Texas when we've refused it.
Could others jump in on the experiences of, go ahead, Steve.
Well, there's a growing body of evidence about the impact of expanded Medicaid. Here are some things we know from a number of studies. First of all, increased access to care, decreased out-of-pocket expenditures for those who obtain coverage, increased use of primary care physicians, increased access to and use of prescription medications, longer wait times because there's higher demand for services, increase in cancer screening, particularly cervical and colorectal cancer screening, an increase in cancer diagnosis at earlier stages, and a decrease in ER visits because those patients now have access to primary care earlier in the stream of illness. So I think there is evidence that there are some positive outcomes, both in terms of access to care and even some health outcomes.
Aisha, I wanted to check in with you on the idea of better medication adherence, more people getting medication they need. I'm not sure if you know of any sort of stats with that, with the Medicaid expansion in states that have done it.
So I don't have the stats on that, but yeah, but I would just say that, you know, given that Texas has one of the highest, if not the highest, rate of uninsured in the country, definitely having the Medicaid expansion would increase that access. By having increased access, definitely you would have more people receiving prescription drugs and being able to take care of take care of those conditions or disease states, diagnoses that they may have, which of course long term is going to have a positive impact on outcomes and particularly healthcare costs, because although we don't have Medicaid expansion, we're still paying for it. You know, they're still in the system. And so there's still, we still have to have a way to pay for those patients who don't show up to a primary care physician's office, but they show up to the ER because they don't have a PCP.
Let's go to Medicare for All. We were chatting a little bit, a few of the panelists and I were chatting before we began tonight about Medicare for All kind of means a lot of things to a lot of people. It's being defined differently by different candidates. There's various bills on Capitol Hill. I just wanted to talk a little bit about what that would actually mean if we had Medicare for All. What would it mean for the employer-based system? How would we finance it? What sort of would we have to have tax increases? There's some concern about that. Just sort of how might that play out? Who would it affect? Who would it impact? Jessica, I don't know if I kicked that over to you. Since we were talking about it, you're on.
I guess I'm skeptical we're going to see this because after the political backlash the Democrats got after the Affordable Care Act, I can't imagine any of them would have the stomach to actually pass something that looked like Medicare for All. I mean, the impact depends so much on what it would look like. I mean, Medicare, there's partly single payer with Part A, Part B, and then it's partly a multi-payer system with Part C and Part D. So, you know, it's hard to say what it would look like. But it would address, you know, if it truly was more like the Medicare Part A, Part B side, I think it would address some of the problems we're hearing. We've been talking about these narrow networks and discontinuity of care. I think one big advantage that Medicare Part A and Part B has on the cost side is you don't have the government negotiating prices. The government, through the regulatory process, says, here's what it is, take it or leave it. And if it was Medicare for all, everyone would have to take that price, right? Otherwise, they go out of business. And so I think it would go very far in driving down costs, but it would significantly change the financial picture for providers.
And surely coming back to the preventive care, the primary care, it surely would make a difference there, you know, for people to have, because people would have greater accessibility, for sure. You can imagine my surprise when a family member said to me a few years ago that they had discovered that the best way to get scans done, they were in the process of needing MRIs, was to go to the ER, because then you didn't have to wait and you could have it done there. And I'm like, please. But think how many people, I mean, think about the cost that's involved with that, and we absorb it somehow. You know, we pay for it anyway. Steve?
So I think different people mean different things about Medicare for all. I think some think of it as universal coverage, and we saw in the survey results that was important to many of the respondents. And a major difference that our healthcare system has with the rest of the wealthy countries in the world that have, by the way, higher value healthcare systems is that we don't have universal coverage. I think other people think about single payer, and I personally think that will be very difficult for our American culture. We value choice, we value diversity in terms of different opportunities and different plans. So I think that one will be more difficult. The advantage of a single payer system is it would probably cut down significantly on the administrative costs of healthcare, which are substantial. But I think universal access is much easier for people to accept and buy into than single payer.
So Vivian, what about the financing? Seema Verma, who's the CMS administrator, had a speech a while ago where she said Medicare for all means Medicare for none, in part because of the financial pressures. I mean, how could we finance this kind of expansion of the Medicare program?
It's going to be very, very tough, and you know, as the other panelists have mentioned, there's big differences in how you would structure this. So I think the Bernie Sanders approach is not going to work, and that's the one that's been commented on, I think, the most. But if we can, you know, I don't know much about how the other countries actually finance their healthcare, and so that's why we're doing a conference in October at the Baker Institute, and we're going to invite in experts from Canada, the UK, and Germany, which is quite different, you know, which has multiple different insurance companies, and see how they do it. So maybe, at first I didn't want to consider this because I thought this is ludicrous, Americans don't want it, but then you have this whole group, you know, politically, I can't ignore the politics, there are people who are saying they want it, so we have to look at it, and maybe we do an incremental approach where we start lowering the age when you can qualify for Medicare. And so then we could still maintain a system that has insurers, like Tim Garson said, through Medicare Advantage. So you have some people in a standard program, and you have other people going through, you know, private insurance companies to get their Medicare Advantage managed care. That's potentially doable because it's one of those sort of favorable things, and people, I think that would be much more palatable than what went on with the ACA. So potentially that could get passed, but I also understand Jessica's view of how the Democrats view health care.
So Vivian, let me ask you about universal coverage. Let's set aside single payer, let's set aside government paying for it all, and just talk about single coverage. As a health economist, do you believe that in the long run, universal coverage would increase our costs or ultimately decrease them?
Oh, I think it will decrease them, but the political challenge you have is that our doctors are now making twice as much, more than twice as much as any other doctors in any other country. So how do you get them to agree to stop making that much money? I just don't know if we can get from, you know, here to there.
Maybe it's a generational thing, right? Like, I mean, when I've spoken to groups of medical students and I ask how many of you want to open your own practice, it's like 2 hands in a group of 30. I mean, I think, I can't speak for everyone, of course, but it seems to me that sometimes some of the younger folks are coming in and they don't want the pressures of a practice and they want to go. And I don't know if they're going to make less than their peers that came before them, but it seems like maybe it will be a generational shift. I don't know.
Well, there are studies coming out that show that physicians working employed by hospitals, actually their patients cost more than physicians working for physician practices. Now, some of those physician practices may be quite large, but this question of, is the physician as an employee going to solve all our problems? Unfortunately, not so, unless you're going to change the incentives for the hospital wanting to rack up more charges too.
So I just want to give the audience a heads up. We have a mic here. I'm not sure if there's one over there. If you could, beg your pardon. Thank you. Why don't you go ahead and line up at mics? I'm going to throw out one more question before we go to the audience, but I really was intrigued by the healthy lifestyles questions, okay? So I just kind of want to throw out whether or not you think these might really shift behavior and shift health outcomes and save money if we had a fat tax, if we stopped the sale of all tobacco products, and then the favorite we were all discussing beforehand, this 0.0 alcohol level, which in fact Tim talked about and we were discussing means you can't have anything tonight before you go home if we went that route. So, but nonetheless, let's start first, fat tax, tobacco tax, or banning rather the sale of all tobacco products. They may not necessarily be realistic, but what could be the outcome for health?
Well, there's some early evidence that the fat tax may work. Philadelphia instituted a sugary beverage tax, and in the short term, the consumption dropped by 40%. I've not seen the follow-up study on that, but there's some evidence that suggests that the fat tax could work.
It could work. Okay.
I'd also like to add to that with the fat tax, if you will, that we do it with cigarettes. And so it whether or not it deters, and that is one of the taxes that continues to go up. But we do have that additional tax with the cigarettes where we charge it. And also when people are making decisions about healthy eating, one of the arguments that you always hear is it costs more to be healthy, to eat healthy. And so if we now started balancing the playing field, if you will, on the foods that they're choosing, maybe, they might decide to, well, I may as well go ahead and get those vegetables, as opposed to that hamburger. I can get the salad, it's the same cost, Sure. But because that's always an argument that you'll hear people make. It costs more to be healthy.
And some of that's availability, and when we think about food deserts and where and what kinds of food is available in what kinds of places. And so if that cost were balanced out, it may be that providers would be able to make healthier foods available in places where they're not so available right now, or much less affordable.
Jessica, what do you think?
I think it is a nudge. I think we've seen from the cigarette tax, it can deter some people from the less healthy behaviors. I just would want to make sure it's not an isolated, standalone solution to the problem of obesity. I think for many people, there are other factors at play. So, Peg mentioned mental health. Depression, anxiety can be a big factor in people turning to food and overeating. And I'm glad she mentioned food deserts because that's important too. And so I'd like to make sure that fat tax was not a sort of standalone address.
It's that whole issue of social determinants of health that everybody's thinking about now. I think one thing that came to mind for me with the zero blood alcohol limit is that, it's really, and we think about, and one of your questions was going to be, how does it shape behavior? And I think that, certainly in countries, I'm familiar with Australia, I have a family member there, and they don't have a zero level, but their consequences are very severe. And people don't drive when they're drinking. Even one glass of wine, they just don't drive. They either do public transportation or Uber. But the other thing that came to mind for me is, are we going to address addiction? Because some of those kinds of behaviors are around the medical condition of addiction. And if we're not going to address those, then it's kind of a crazy sort of fix.
Do you want to jump in as an economist on human behavior on these, or?
Go for it.
Oh, I don't know. I'm just thinking all sorts of unintended consequences. I don't know how you impose a fat tax without dealing with the restaurant and food and agricultural lobby. I think that would be very tough. Just in terms of, I like what Peggy said about just impose stiffer penalties. You know, that'll that's a terrific idea. And then I don't know. I just, when those slides went up, I also wish there could have been a baseline question of, you know, how many would prefer a complete ban on guns in this country? Because that's what has been the public outcry. And so, you know, some of these things are stronger than that to me, and sort of. I don't know. I just can't figure out what's going on in people's heads.
All right. Well, maybe that's the next survey. All right. Okay, sir. Would you like to start?
I will.
And please, just one second. Yeah, tell us who you are and just get right to your question. Great.
My name is Jacob Clementich. I am a member of the St. Joseph Clubhouse, which is a mental health organization here in Midtown and by the Search Building. At any rate, what I want to say is this about the catastrophic Medicare. What about mental health issues? Would they count as a catastrophic issue, just like a physical catastrophic issue, such as a brain injury?
It probably depends on how they would design the plan, I would think.
I would think that they should be, mental health issues should be counted equally with physical health, because there are plenty of studies now showing that
that a lot of the cost of caring for chronic illnesses has to do with the depression that the patient has. I don't know which comes first, but if you're going to deal with chronic care and those costs, you got to provide the mental health coverage at the same time.
And there is a federal law, mental health parity law, which means insurers are to cover mental health issues the same as they cover physical ailments, but there's been big debate about whether or not that's been implemented as intended. So
exactly.
Go right here.
Hello. Okay, I think it's going. My name is Cedric Dark. I'm a physician here at Baylor College of Medicine. My question is a little bit towards Mary Agnes, but then everybody else that wants to respond is perfectly welcome to do so. Kaiser gives me a little tiny stroke every time they come up with one of these Bills of the Month segments, because I'm an ER doctor.
Which we do with National Public Radio. Just to
They're great. They're great stories.
Great, yeah.
I love the stories.
Thank you.
However, a lot of this is focused on balanced billing, and I think a lot of the conversation typically is in response to sort of emergency conditions. So I would agree that I don't think patients need to be balanced billed if they are going to go see their hip surgeon for elective hip replacement. Their hip surgeon shouldn't charge them an extra $1 million because they're out of network, because there's the opportunity to go ahead and pre-price things. But in the emergency situation, there's a law called EMTALA, which essentially says that every ER doctor in every hospital has to see whatever patient walks through the door, whether or not that patient intends to pay the bill. Like Dr. Garson had referred, he may not want to pay the bill until it goes into collections period. Or whether or not the insurance company wants to pay a bill for an emergency services anyway. So my question is, there's this difficulty in terms of negotiation for emergency conditions between providers and payers. And what's your solution to fixing that?
Well, actually, there was just a story on Kaiser Health News that examined this, because several states have laws to protect consumers from balanced bills, but they don't apply to the self-insured plans. Because the self-insured, and again, those are plans where the company pays its own medical expenses, doesn't pay premiums to insure, but they may have an insurer like a Cigna or an Aetna do all those bills, do all the paperwork for them, right? So, but if you are self-insured, ERISA is one of those laws that exempts you from that and other state laws, right? So the ideal solution, which probably isn't going to happen politically, is that Congress goes back and visits ERISA and amends it to say, perhaps in an emergency situation or under these conditions, hospitals are not allowed to balance bill the patient, right? And so that could be, it seems to be the quickest, fastest way to fix that. But because we can't write a story about every person who has a huge balance bill, and because I know at least for the last two, they both got reduced like that the minute you get the call and start getting the attention, that kind of thing. But maybe the bigger solution is the conversation we're having around it, that those stories are inspiring to get people to think about it. Because it's not only tough for that family that's dealing with that, it's really bad PR for the hospital. I mean, for the last hospital mentioned in the heart attack situation, there was a memo put out, this is not how we want people to think about us, this is not what our values are, but yet they were the ones sending the $109,000 bill to a school teacher who made about 42 grand a year. So go ahead, please.
Hi, Ken Yonda with Community Health Choice. I was hoping that Dr. Dark would stay and that we could have a across the aisle debate about this. But just to comment on that from the insurance company perspective, this is the emergency room billing stuff is something that is about to explode in the state of Texas, and I think it's happening nationally. And here's just the kind of quick Texas stat on this. For a complex emergency room visit to pay Dr. Dark, for Medicaid, he accepts $100. This is not, we just go with it, Cedric, okay? $100 Medicaid, which is not enough to cover the cost of their care, right? Medicaid paid. It's $175 for Medicare is what the national Medicare fee schedule would be. In Texas, the workers' comp law would say that they would pay about $250, more than Medicare for that. Most PPOs would then pay probably, say, $350. And the 50th percentile of the bills that we get in from emergency room physicians is $1,500. So the issue then becomes, as we try to contract with emergency room physicians about this, what is in fact a fair price for a service where the consumer really has no choice, right? And that's the real challenge. As Cedric said, for a elective surgery, you can actually shop around and see who will do your gallbladder surgery.
So you work for an insurer? I'm sorry, I didn't catch that.
Yeah, I'm the CEO of an insurance company, sorry.
Okay, can you tell us which one?
Community Health Choice. Okay. We're a local nonprofit. We cover about 400,000 people here, but it is a huge problem that different states are attacking in different kind of ways. But as you point out, I think every state in the country has got to deal with it because it's very difficult to deal with network issues when it's emergency services. And that's one of the things that we as insurance companies are at fault for, not recognizing there's differences when people don't really have a choice than when they do have a narrow network.
Great, thank you. Right here.
Hi, good evening. My name is Gwendolyn Jenkins. I'm the Executive Recruitment Manager at UT Health. One of the things and the questions that I asked, anyone in the panel can answer, but what do you think about the impact of Medicaid fraud? Some of the things that were mentioned, and it just made me look back at an article that I recall this summer that came out where the Texas Supreme Court ruled against Xerox, formerly, that they found them guilty of $2 billion in fraud over a 6-year period. So just as we think about some of the things we talked about, cost shifting and waste from duplication of services, what do you think the impact would be if we could eliminate fraud or decrease it?
I don't know if someone wants to start about, I'm not sure who, I mean, I haven't, Jessica, did you want to say something, Jessica, or no?
I mean, I wish I had the statistics in front of me, but I don't know that, yeah, I was going to say, I'm not sure fraud is I don't want to say it's not a problem, but it's a small piece of the overall cost picture, so I'm not even sure if we eliminated fraud completely, and I don't know how you would do that you could, it would help with cost issues, but I don't know if it would get that far with health issues, right? And it's just it would be a one-time savings too if you could just eliminate it. But I also can't imagine how you would do that. Because the rule, I mean, so for example, I mean, one way you start to eliminate fraud is you have more audits and require more data from providers so you can ferret it out, and then they're gonna be like, oh, these administrative costs, we have all this paperwork we have to do, or all this data, so there's a difficult trade-off there.
So I think the amount that is wasted through fraud is actually higher. There were some higher percentages in this book overcharged. They may have overblown it, but it's significant there. So it's a question of attacking fraud in a smart way. So for example, the compliance issue is a problem. Community health choice. I then also have to listen to these board meetings about some of this paperwork that a perfectly decent, legitimate insurance company has to fill out, and that's just a waste of money. However, I think there are a lot of tracking types of things. When you talk about the types of frauds of people going in and starting up pill mills and pulling in fake patients and billing hundreds of them or thousands, the federal government doesn't spend enough on that. So it's getting smart on it, and I think it's pretty clear with the amount of fraud that there is a big financial return if you do it right. And I think it would be worth it for the federal government to hire some really smart IT people, pay them a lot of money, and you will get your return back. And I don't know why they're doing it. I've heard a long time ago you would get $17 return expenditures on fraud for every dollar spent.
It's actually very interesting reading. If you go to the Department of Health and Human Services, has an Inspector General's office that will tell you every year what they're investigating and what they find. And I think between the HHS Investigator General and the Government Accounting Office, you will find a lot of work on fraud. But you make a good point. It certainly bears watching. So, okay, thank you. Thank you. Next speaker, please. Next questioner, rather.
Hi, I'm Zawadi Bryant. I'm CEO of Nightlight Pediatric Urgent Care. And my question goes back to the compensation for physicians. And so we're at a point now where the insurance companies are reducing our reimbursement rate, and so we're actively having to look at mid-levels. And so we're kind of working with patients on understanding the quality of service. It's great with mid-levels, because they're like, I want to see a doctor, I want to see a doctor. And so we're in that space where it's, you have to justify, getting reduced reimbursement fees. The cost has to come out somewhere, right? So the question is in regard to the expectations of compensation for physicians. I'm wondering, if I was strapped with the amount of medical school bills that they are, I would want a big payout as well. So is there anything being done to address the cost of going to medical school? Because I have friends that are doctors in other countries, and their medical education is paid for. So is there anything being done about that? And then also, is there anything being done about incentivizing medical students to go into primary care? Because when we go to the Baylors, when we go to the UTMBs, and we talk to med students about urgent care, about pediatrics, they're not interested. They want to be cardiologists, and they want to be specialists.
Because of the money?
Because of the money.
Okay.
Yeah.
Steve?
Well, since I'm building a medical school that is focused on turning out more primary care doctors, I know a little bit about this. One of the things that is being done, NYU just announced a few weeks ago that all of their medical students are going to go through medical school fully scholarship, the tuition and fees free. And we announced a few weeks ago that our first class will go through for 4 years, tuition fees free. I hope that we can continue that, but it will require a significant amount of philanthropy to do that. I don't think that the only reason that most medical students, 80% in fact of U.S. medical graduates, choose non-primary care specialties is money. I think that's an important, that is some part of it. But there are a number of other factors, including the curriculum, the hidden curriculum, the culture, which often tells medical students you're too smart to be a primary care doctor. The intake, the kinds of people we bring into medical school, when we just focus on MCAT and GPA, that probably is not a good measure of whether or not students are going to want to do primary care. And then last but not least, the financial issues. So I think there are there is a number of ways to get students to choose primary care short of financial incentives, but absolutely, if we could find ways to fully scholarship or fully repay loans to students that go into primary care, I think we'd see a significant uptick in the number that choose that.
Some of the bills for some of the proposed single-payer legislation is looking, or include provisions that would pay for medical school the way it's done in other countries. Again, I don't know how you pay for that, but.
And since you mentioned mid-level providers, then I have to speak to that a bit. Our experience has been, and I think the literature supports this, or there's evidence for this, that people tend to be very happy with mid-level providers. They're not. They sometimes will prefer that. I'd rather see the nurse practitioner than the physician because he or she talks to me or listens or whatever. But it's very, there are a lot of challenges. Maybe more so in Texas than in some other states, the scope of practice is fought for. I mean, it's like, tooth and nail for every little piece of scope of practice just to do what they're trained to do. It's quite a fight in the legislature. And so there's also evidence about how cost containment could certainly be improved if we could use mid-level providers more readily than we're able to. Thanks.
Great. Well, with that, I think we're done with questions. And Tim, we've got, I'm sorry, one more question. Okay, and then I'll turn it back over to Tim.
My name is Bob Longoria. I'm the CEO of Circulation Concepts. We're a developmental stage company at J Labs, and we deal with technology at J Labs every day. And I would like to know if there's some kind of initiative that's looking at technology to lower overall health costs, because technology has been responsible for many severe increases in health costs in the past. What would the panel say about an initiative to lower health costs using technology?
So there are some traditional measures that are used to evaluate technologies, and they're called cost effectiveness analysis, where you essentially look at the impact of implementing that technology on quality adjusted life years. And there's some metrics that are typically used to decide that. Certainly some technologies are significantly cost savings. Others, while there is some incremental benefit, the incremental cost is such that they're not cost effective. I think we could do a better job of carefully analyzing the cost effectiveness of new diagnostic and therapeutic technologies, but that would require that certain ones that are not cost effective not be adapted and paid for in our healthcare system.
With that, I see Tim at the podium, so I will yield.
So you've managed to watch history unfolding in front of you. And that is that Garson sat on a stage and didn't say anything for an hour. And with that, you guys are amazing. Mac, what a great panel. I mean, I kept wanting to dive in, and Stephen kept saying, no, you can't. So really, thank you all for sticking this out. Remember, great meeting ends early, and an outstanding meeting ends early and has food. So we've got about 30 seconds. There is food, there is drink. The blood alcohol level is not supposed to be 0.0. And on that note, thank you for coming.